BHIVA guideline, okay, British HIV Association guideline for the management of HIV in pregnancy and postpartum, 2018. So 2019 second interim update we are going to discuss. So we begin with our quote, master MRCOG with concept oriented clarity. Okay. So we know that HIV, that is human immunodeficiency virus, it is a retrovirus that primarily infects CD4 T lymphocytes, leading to progressive immune suppression. It is transmitted via blood, sexual contact, or vertical transmission, mother to child infection during the pregnancy, delivery, or breastfeeding. HIV uses the enzyme reverse transcriptase to convert viral RNA into DNA. It will integrate into the host genome via integrase and produces new virions with the help of protease. Okay, so these are different things which you should remember. There is a reverse transcriptase, there is an integrase, and there is a protease, and the drugs are acting on this, so we need to know about it. Okay, without treatment, HIV infection progresses to acquired immunodeficiency syndrome, that is AIDS, characterized by the opportunistic infection and malignancies. BHIVA guideline provide evidence-based recommendation for choice, timing, and monitoring of ART in pregnancy. Understanding drug classes, mechanisms, safety profiles, and pregnancy-specific consideration is important from our examination point of view. Okay, so listen to these drug classes, what is their mechanism in the subsequent slides, and then we'll go for the various regimes. Okay, so coming to the various drugs which are used, the drug classes are NRTIs, NNRTIs, then PIs, and INSTIs, also called as integrase inhibitor. These are main four. Others are also there in the subsequent slide. We'll go into the details later on. So coming to the NRTIs, that is nucleoside or nucleotide reverse transcriptase inhibitors. Okay, in which we have zidovudine, lamivudine, that is 3-TC, then abacavir, tenofovir, then imicitrabine. Okay, so these are NRTIs, reverse transcriptase inhibitors, nucleoside or non-nucleoside reverse transcriptase inhibitor. What is the mechanism of action? They are analogous of natural nucleosides or nucleotides. They get incorporated into the viral DNA by reverse transcriptase and cause chain termination. They will block elongation. Okay. Then coming to the second category, NNRTI. Okay. So non-nucleoside reverse transcriptase inhibitors. The examples are efavirenz, nevirapine, rilvegostomig, then itraverin. So these are the NNRTIs. Okay, how do they act? They bind directly to the reverse transcriptase enzyme, allostatic site, cause conformational change, and inhibit the enzyme activity. So no DNA synthesis. So these NNRTIs will bind to the reverse transcriptase enzyme. Okay, they will cause conformational change and inhibit the enzymatic activity. Then coming to the PIs, that is protease inhibitor. These are lopinavir, ritonavir, atazanavir, darunavir, and indinavir. Okay, so remember these protease inhibitors are navirs. All navirs are protease inhibitors. Okay, lopinavir, ritonavir. So all navirs are protease inhibitors. How do they act? They will inhibit the HIV protease enzyme, will prevent cleavage of viral polyproteins, and leading to immature or non-infectious viral particles are formed. Okay, so they will act on the protease enzyme, and all navirs are protease inhibitors. Then coming to the integrase strand transfers inhibitors, that is INSTIs. Okay, also called as integrase inhibitors. All integrase inhibitors, integrase, here comes G. Okay, so all gravirs are integrase inhibitors. Okay, gravir, integrase inhibitors. So you have raltegravir, dolutegravir, elbitagravir, then bictegravir. Okay, so these are integrase inhibitors. They will block the integrase enzyme, will prevent integration of viral DNA into the host genome. Okay, so these are the mechanism of action. Please go through all these drugs later on. Okay. Then other drugs, other classes are entry or fusion inhibitors, in which you have enfuritide and maraviroc. Okay, so enfuritide is a T20 fusion inhibitor, and maraviroc is a CCR5 antagonist. Okay, this enfuritide is binds to the GP41 on viral envelope. It will block fusion with the host cell membrane And Maraviroc blocks the CCR5 receptor on the host CD4 cells and prevent HIV entry. Okay. And then you have post-attachment inhibitor, that is a monoclonal antibody, emalizumab. It binds to the CD4 receptor after HIV attaches and prevents conformational change needed for entry. Then attachment inhibitors, fostemsavir. So it will bind to the GP120, prevents attachment of HIV to CD4 receptors. But at least previous slide drugs you should know, these are not frequently used. Okay. Then exam tip, always mention MDT care and psychological support in management. Depression screening is done at 3 points. Okay. Booking 4 to 6 weeks postpartum and 3 to 4 months postpartum. Okay. And second, sexual health screening and BASH guideline based treatment are key audit standards. Coming to the psychosocial care for women living with HIV. Psychosocial issues around HIV and pregnancy are known. Okay, antenatal HIV care should be delivered by a multidisciplinary team and offer peer support to pregnant women living with HIV where available. Okay, and perinatal health assessment, just now we have seen 3 times you have to do. One is at booking visit, screening for antenatal postnatal depression. One is at booking visit. Second is 4 to 6 weeks postpartum, and third is 3 to 4 months postpartum. So these are the time at which you will do the screening. Okay. Now coming to the screening and monitoring of pregnant women with HIV. Sexual health screening. If the lady is newly diagnosed with HIV in pregnancy, you will offer full sexual health screening. That means you have to screen for other sexual infections also, other STIs also she will be screened, provided she is newly diagnosed with HIV during the pregnancy. If the lady is already diagnosed and she becomes pregnant, in that particular case, sexual health screening is suggested. Here it is offered or recommended. Here it is suggested. Okay. And then treat genital tract infection as per the BASH guidelines. Lab monitoring, no extra baseline test in a newly diagnosed pregnant women beyond standard antenatal and HIV care. So whatever the tests which are required for the HIV care, only those tests and routine antenatal tests are required, nothing more than that. Then how many times you will do the resistance testing? How many times you will do the CD4 monitoring? How many times you will do the viral load monitoring? This is all you should know. Resistance testing is done before ART initiation, except in patients who are presenting late. That is, they are presenting after 28 weeks. Then the resistance testing is not done. But early trimester you are starting, then do the this resistance testing. Repeat if ART is stopped after delivery to detect missed mutation. So if it will be repeated, this resistance testing will be repeated if she stops after the delivery. Then CD4 monitoring. How many times you will do? If she is on CRT before conception, she is already known case of HIV and she becomes pregnant, baseline and delivery. 2 times you have to do the CD4 monitoring, baseline and delivery. And even if the ART started during the pregnancy, then also you have to do 2 times, baseline and delivery. Okay. Even if the CD4 count is quite good. Okay. Then viral load monitoring. How many times you have to do? One, first thing you will start combine ART. Then 2 to 4 weeks after starting the CART, you will do the viral load monitoring. Then you will carry out once in each trimester, and at 36 weeks and delivery you will carry out. So 3 times you have to do, 2 to 4 weeks after starting the treatment. Then you will repeat in each trimester. So this is already done in the first trimester. Then you will repeat in each trimester. The final is at 36 weeks. Okay. LFT is baseline at CART initiation. With each routine blood test, you will be carrying out LFTs. Okay. If viral load is not suppressed, so what is the purpose of starting this CART or this combined ART is to suppress the viral load less than 50 copies per ml. Okay. Now, if the viral load, so you have repeated this viral load 2 to 4 weeks, and you find that this viral load is not suppressed, then you have to review the adherence and drug interactions, perform resistance test, and consider therapeutic drug monitoring and optimize or intensify regime. Okay, so these are the things which you will carry out. Then what is the choice of third agent in combined ART? Preferred is efavirenz or atazanavir. That is the most safety data. Alternatives are rilpivirine, raltegravir, and darunavir. Okay. So gravirs are integrase inhibitors, okay, and navirs are protease inhibitors, okay. Darunavir uses 600 milligram BD if resistance or if started in the pregnancy, okay. Dolutegravir not to be used before 6 weeks. It can be used after 6 weeks. This is a SBA. Okay, dolutegravir, what does it cause if used before 6 weeks? Just find it out. I think it is a neural tube defect, most probably. Okay, it is not recommended. Then which drugs are not recommended? Zidovudin monotherapy is not indicated. So this monotherapy can be used only when the viral load is less than 10,000 and the patient is for elective LSCS. Otherwise, zidovudin monotherapy, always a CART, that is combined ART is used. Okay, monotherapy is not preferred. It is used except in conditions where the viral load is less than 10,000 and a patient is for elective LSCS. Okay. Then PI monotherapy, TF, darunavir, cobic, these are not preferred combinations. Okay, integrase inhibitor best regimen. Consider if viral load is very high, more than 1 lakh, or there is a failure of CART. In that particular case, integrase inhibitor, that is, they will have gravirs with them. Okay, so these integrase inhibitors will be preferred if there is a viral load high, more than 1 lakh. Okay. Now, if the lady is presenting late, woman not on treatment, we have already seen that resistance testing is not required if she is presenting late. But what we will do if she is presenting late, then after 28 weeks, we will start CART immediately. If the viral load is unknown or more than 1 lakh, use 3 or 4 drug regimen and always go for integrase inhibitor, that is gravir. Okay, and the dose is 400 milligram BD or dolutegravir 50 milligram OD. Okay, so this also you should remember. They may give you the scenario, she is late booker. Okay, she is booking late after 28 weeks. So your action will be start CART immediately. If the viral load is more than, then go for 3 or 4 drug regimen, one of which has to be integrase inhibitor. If you are using raltegravir, then 400 BD, and or if you are using dolutegravir, then 450 milligram OD. Obviously, dolutegravir cannot be used in early 6 weeks, and she is presenting at 28 weeks, so dolutegravir can be used. Okay, at 28 weeks. Then untreated women presenting in labor. Now you have a scenario in which the patient is not on CART and she comes to you in labor. Then what you will do? You will give nevirapine 200 milligram stat, that is NNRTI. Then you will give NRTI, that is 2 drugs from NRTI, 1 drug from NRTI. So 2 drugs are zidovudin 300 milligram and lamivudin 150 milligram BD, and raltegravir, that is integrase inhibitor 400 BD, and also you will give IV zidovudin throughout the labor. Okay, so here again 4 drug. Okay, 2 NRTIs, 1 NRTI, and 1 integrase inhibitor. Is it clear to you? Is it clear?
Yes, sir.
You may get confused little with the doses and all, but don't get confused with the doses. Just remember the drug, names of the drug. Okay. At least you will come to know, if you remember this way, 2 NRTIs, 1 NNRTI, and 1 protease, 1 this integrase inhibitor is required along with IV zidovudin throughout the labor. Okay. Then if she is a preterm labor, the infant is unlikely to tolerate oral medicine, so add double dose tenofovir DF. Okay, so these patients require tenofovir in preterm labor. Okay. Unknown HIV status in labor, SROM or urgent delivery, perform urgent HIV test. If she is reactive or positive, start interventions immediately. Don't wait for the final confirmation. Okay. So when the lady comes with HIV status unknown, urgent, because this will be the point of care test. So if your point of care test is positive, don't wait for the you start with the intervention. Okay. This is what the guideline says. Then pharmacokinetics for ART in pregnancy. No routine dose changes except raltegravir is converted 400 milligram BD. Otherwise, raltegravir in a non-pregnant status, I think it is OD, but in pregnancy it requires 400 BD. Okay, and tenofovir will require TDM monitoring. Only these are the only 2 things which you should remember. Okay. If off-license dosing, if suppose she is not on a standard regimen, then you will shift her to the standard dose or do regular therapeutic drug monitoring. Stopping of the ART postpartum is not advised. Whether she is started before pregnancy or during the pregnancy, ART is to be continued throughout. Okay, even after delivery. So stopping is not recommended. If woman wishes to stop, provide counseling and follow BHIVA audit ART guidelines. HIV and HBV co-infections. Now next category. Up till now we have just seen the lady with the HIV and different situations. Like she was not in ART coming in labor. Okay. And now the situation is she is HIV and associated with hepatitis B virus infection. Then how to deal with that scenario? Suppose if it is a new hepatitis B virus infection, recent diagnosis, we will confirm it with HBV DNA. Also, other HB antigen will be done. Then other viral markers also we have to do. Hepatitis A, hepatitis C, hepatitis D you have to screen. LFTs you have to do, and look for the fibrosis, how much fibrosis is there or liver damage is there. Okay, LFTs you will check at 2 and 4 weeks after ART start, and then monitor regularly. Okay, if the pregnant on dual active, suppose she is already hepatitis B positive, okay, she is already on ART before pregnancy for both, then we will continue the same treatment. Okay, here just remember in hepatitis B, the drug of choice here is a tenofovir plus imicitrabine or lamivudine as NRTI backbone. Here tenofovir has come. Okay, if TDF is not included, add it. So tenofovir is preferred if the patient is a infected with hepatitis B virus. Okay. Now further thing is that if 3TC lamivudine or FTC resistance, then TDF can be used. That is why I said tenofovir is the one of the hepatitis B. Remember tenofovir. Okay, do not use lamivudine plus imicitrabine alone. It has got a high risk of resistance. Imicitrabine is preferred over lamivudine. Okay, better antiviral effect. Then you will also, if she is negative for there is no hepatitis infection, then you will go for vaccination. If she is not immune, vaccinate either 2 doses or 3 doses. 2 doses are 0 and 6 months, and if her CD4 count is less than 300, then she will require 3 doses of hepatitis A vaccine, that is 0 month, 1 month and 6 months. Okay, so hepatitis B patient is to be screened for other viral infections also, like hepatitis A, C and E also. Okay, and if she is not immune, then we'll give hepatitis A vaccination either 2 doses or 3 doses. Okay, 3 doses will be given if the CD4 count is less than 300. Okay, and continue dual active ART postpartum also. Postpartum hepatitis flares managed conservatively with monitoring. And as far as mode of delivery is concerned, if your HIV viral load is suppressed, then vaginal delivery is acceptable irrespective of the hepatitis B virus load. Hepatitis B viral load does not affect the mode of delivery. Remember, what affects the mode of delivery is the HIV viral load. Okay, any idea how this HIV viral load will affect the delivery? Can anyone tell me if anyone knows? Any idea? Dr. Sinchana, any idea about the viral load?
No, sir.
Okay, so if you have co-infection, disregard the viral load, concentrate on the HIV viral load. Okay, and if the she is fully suppressed, then the vaginal delivery is acceptable. Okay, for neonates, what you will do, what we do routinely, hepatitis B vaccine plus immunoglobulin within 24 hours of the birth. Okay, the same thing is for the neonate. Don't forget the neonate. Okay, sometimes they will ask you the management, and you will if you have an option with the neonate, then select the option with the neonate, because that will form the complete so treatment for the mother as well as baby. Okay, now hepatitis B we have finished. Now third is a hepatitis C virus. If there is a HIV and hepatitis C virus infection, in hepatitis B, which drug we have seen? Tenofovir. Okay, now let us see what is there in HCV. Now suppose if she is a case of new HCV diagnosis, then we will confirm as usual with the HCV RNA, genotype, assess for fibrosis, LFTs and other liver disease. LFTs will be repeated 2 to 4 weeks after ART starting, and then we will monitor regularly. Here, the ribavirin-based DAs are contraindicated in pregnancy. Stop immediately if the woman becomes pregnant. So, if she is already case of HCV and she is receiving ribavirin, that will be stopped. Okay. Women planning the pregnancy expedite DAA-based HCV therapy before conception, and HB vaccination is recommended if not immune after first trimester. So, in hepatitis C virus, we are also going to screen for B and A also. And if she is negative for B, we will after first trimester the hepatitis B vaccination can be given. Same like hepatitis for hepatitis A virus in vaccination, 2-dose schedule, 3-dose schedule, 2-dose schedule routinely given. If the CD4 count is less than 300, go for 3-dose schedule. Mode of delivery same. Vaginal delivery is acceptable provided she is on antiretroviral drug and there is a full viral suppression and disregard the viral load of the HCV here. Okay. Postpartum continuous ART in all women with HIV and HCV irrespective of the HCV status. Okay. And coming to the obstetric management. Okay. Now what we have seen up till now, was the lady with the HIV infection. Then we have seen co-infection with hepatitis B. Then we have seen co-infection with hepatitis C. Now coming to the obstetric management for a patient with who is on ART. Okay, combined ART. Antenatal care, routine fetal ultrasound as per national guidelines. Then you will do the combined screening plus NIPT as usual. Then invasive testing. If this patient requires invasive testing, avoid until HIV status is known. Ideally defer until viral loads is less than 50 copies per ml. Remember this particular figure. This is a key figure. Less viral load less than 50 copies per ml. This can be SBA or EMQ that they are asking that the particular patient requires invasive testing, either amniocentesis or cordocentesis or CVS, etc., etc. And she is not screened, then first you get the HIV testing done. Okay, if she is negative, no issue. Okay, but if she is positive, then you have to start treatment, find out the viral load. Once the viral load is less than 50, then you will carry out the invasive testing. By any chance, if it is urgent and you cannot wait for the invasive testing and she is not on CRT, then start CART immediately. Include raltegravir, okay, plus single nevirapine dose and 2 to 4 hours pre-procedure you have to give. Okay, so you will start CART therapy, which includes raltegravir. You will also give single dose nevirapine 2 to 4 hours prior to the procedure. Okay, then if the viral load is less than 50, she can also undergo ECD. Okay, so once the viral load is fully suppressed or less than 50, then vaginal delivery is also possible, ECV is also possible. She can also undergo invasive testing. Is it clear? This viral load is going to be a key figure. Okay. Now coming to the mode of delivery in patients who are on CAR. Decide delivery mode based on viral load at 36 weeks. Okay, this viral load at 36 weeks will decide the mode of delivery. Viral load less than 50 copies per ml, she can be up for planned vaginal delivery. Okay, so vaginal delivery is an option if the viral load is less than 50 copies per ml. If the viral load is between 50, remember they give you exact 50. The 50 is here, less than 50 is here. So vaginal delivery is for 49, not for 50. Okay, viral load is 50 to 399 copies. Consider PLCS, that is pre-labor cesarean section. Here it is a consider PLCS, and it will depend upon the viral load, treatment duration, adherence, obstetric factors, and women's views. So multiple factors you will take into account, and you will consider PLCS or the pre-labor cesarean section. And if the viral load is 400 or more, directly go for PLCS. Is it clear?
Yes, sir.
Mode of delivery. Okay, here it is consider PLCS considering various factors. Here it is recommend PLCS. If vaginal delivery is planned and the labor starts, she will be managed like any low risk patient, like any HIV negative, except under cases of rupture of membrane. Okay, VBAC is allowed if the viral load is less than 50. So they can combine your VBAC guideline along with this particular guideline, and they will expect a combination of both. Whether this patient who is HIV positive, she has received so many treatment, and now she wants VBAC. Okay, so VBAC is allowed if the viral load is less than 50 copies per ml. Now, cesarean section. Suppose for cesarean section is performed for HIV prevention, then it is to be performed at 38 to 39 weeks of gestation. This is also a SBA. What is the gestation at which cesarean section is carried out for HIV prevention? It is for 30. It is carried out at 38 to 39 weeks. And if it is done for cesarean section for obstetric reasons, when with viral load less than 50, okay, viral load less than 50, vaginal delivery option is available. But for any other obstetric reason, suppose there is a CPD or any other reason, there is a in spite of this you are carrying out, then it should be done at 39 weeks of gestation. So remember, for what is the indication of cesarean section, that will decide the gestational age at which it is to be carried out. Is it clear to you, this timing 38 to 39 when it is expected for HIV prevention? And if it is done for obstetric, then it is for 39. It is done at 39 weeks. Okay. Now coming to the SROM. If there is a spontaneous rupture of membrane. Okay. If it is a term SROM, AM delivery within 24 hours. Patient should be delivered within 24 hours. Now we know if the viral load is suppressed, she can go undergo delivery. But in that particular case, we are not going to wait for spontaneous onset. How many patients will go in spontaneous labor within 24 hours of SROM? Yes, Dr. Sinchana?
60%.
60%. But here you will augment immediately and deliver the lady within 24 hours. And if there is a pyrexia, you will treat. Okay. If viral load is between 50 to 39, 399, recommend immediate CS. Consider viral trend, adherence, obstetric factors, but recommend LSCS. Okay. In cases of SROM. If the viral load is more than 400, immediate CS is recommended. Now, if it is a preterm SROM, but more than 34 weeks of gestation, that manage this as a term SROM, but add GBS prophylaxis. Okay. So if it is a SROM after 34 weeks of gestation, then manage this as a means you will go for induction or augmentation of the labor. Okay. Provided the viral load is this. She will fit into this category, or she will fit depending upon the viral load. So you will carry out same as this, but you will add GBS prophylaxis. If it is a preterm SROM less than 34 weeks, because prematurity here prevails. So what is there? Give steroids, optimize ART if the viral load is not controlled. Okay, so here the conservative management is followed before 34 weeks of gestation, and multidisciplinary discussion on timing and mode of delivery will be done. Is it clear? SRM before 34 weeks, what the guideline says? Give steroids, optimize ART, carry out multidisciplinary discussion for timing and mode of the delivery. Okay. So here they are taking care of the prematurity. After 34 weeks, it will be considered management will be same as a term SROM. Okay. Now intrapartum zidovudine. Which patients require this? Also you should know. Intrapartum IV zidovudine recommended if viral load is more than 1000 and she is presenting in labor or SROM, or she is for planned cesarean section. So when your viral load is more than 1000 and she comes in labor or there is SRM, you will give intrapartum zidovudine. Okay. And we have also seen intrapartum zidovudine when it is given when she is not on CART. At that time we have given 4 drugs and one of them was IV zidovudine. Okay. Okay. Then untreated in labor and SRM with unknown viral load. And third is consider when viral load is between 50 and 1000 despite CART. So these patients require IV zidovudine. When viral load is more than 1000, when she is untreated and presenting in labor, or there is SRM with unknown viral load, or we will consider if it is between 50 and 1000. Okay. Then place of birth, there has to be associated pediatric care. Water birth, there is a limited safety data, but may be supported if the viral load is less than 50. Okay. Now coming to the postpartum management of these patients. Okay. Antiretroviral therapy, you will continue. CART is continued post-delivery. Support services, assess needs postpartum and refer to trust, community, voluntary services, postnatal depression, mental health. You are going to check for this patient. There will be multidisciplinary management. Okay. Contraception will be discussed. ART may be changed to suit contraceptive choice. Cervical cytology, schedule 3 months post-delivery as per NHS guideline. Partner and child testing. For newly diagnosed women, test partner and older children also. There are no SBs here on this slide. Okay. Yes, from here onward, the important topic starts from ESB and EMQ, especially EMQ point of view. Okay. Infant PEP. Okay. They have divided these infants into 3 categories. Okay. First category is a very low risk category, which requires 2 weeks of zidovudine monotherapy. Remember, for infant, the monotherapy is considered, but for mother, monotherapy is not indicated except where she is for elective LSCS and the viral load is, once we have seen, more than 10,000 or something like that. But for infant, if the infant is a very low risk, then 2 weeks of zidovudine monotherapy is given to the infant. Okay, this is the infant PEP. Now, which are the very low risk babies? Where the mother is on CAR therapy for more than 10 weeks. There are 2 viral loads which are done at 4 weeks apart and the value is less than 50. And last viral load which is done at 36 weeks is less than 50. So if all 3 criteria are satisfied, then we consider that this baby is a very low risk baby and we give only 2 weeks of zidovudine monotherapy to the baby. So mother should have received CAR for more than 10 weeks throughout the antenatal period. There should be 2 viral loads which are done at 4 weeks apart and it should be less than 50, and viral load at 36 weeks should be less than 50 to consider this baby as a very low risk baby. Okay. Now, second category is a low risk baby. This low risk baby will require zidovudine monotherapy, but it is for 4 weeks. Okay. Now, which are these low risk babies? Here, maternal viral load is less than 50 at 36 weeks of gestation, but all 3 criteria are not satisfied. I hope this is clear. When all 3 criteria are satisfied, the baby becomes very low risk. All 3 criteria are not satisfied, but the last criteria that at the time of delivery, after 36 weeks, whatever is the viral load, that is less than 50, but not all criteria are met. Or if it is a preterm less than 34 weeks with maternal viral load less than 50, then the 4 weeks of zidovudine monotherapy is given. But if it is a high risk, that means viral load is not less than 50, then you have to give combination PEP if maternal viral load is more than 50 at birth, or if it is unknown viral load, or if there are adherence concerned about from the mother, then PEP is given started within 4 hours of the birth, and it is a combined drugs, not the monotherapy. Okay. Now, if the mother is having resistance, if there is a resistance in that particular case, still zidovudine monotherapy is given to the baby. Okay, very low and low risk. In here we are giving zidovudine monotherapy, and there are resistance to the zidovudine in the mother, but still for the baby you give very low or low risk category zidovudine. Is it clear to you? In spite of maternal indicated for the baby, provided the baby is either low risk or very low risk. Okay. Now you have got a for high risk with resistance. Okay. But if the baby is high risk and there is a resistance to the maternal resistance is there, then what is recommended? You have to give zidovudine, lamivudine, nevirapine. And if it is HIV2, in that particular case, use zidovudine, lamivudine, and raltegravir until advice. Okay. So very low and low risk, you will give monotherapy. But if it is a high risk with maternal resistance, it is a this zidovudine, lamivudine, nevirapine for HIV1, and for HIV2, zidovudine, lamivudine, raltegravir. Okay. And do not extend more than 4 weeks, even if she is breastfeeding. This infant PEP is not indicated for more than 4 weeks. Okay. In all groups, maximum it is given for 4 weeks. Here also 2 weeks, but monotherapy. Here 4 weeks, but monotherapy. Here also it is 4 weeks, but the combination PEP. Is it clear now? Very low risk and high risk?
Yes, sir.
Yeah. questions are asked here. That particular slide is going to be very important. Then what is the timing of starting pneumocystic carina pneumonia prophylaxis to the neonates? This is started at 1 month. Okay, if the infant HIV PCR is positive or confirmed HIV, stop only if HIV is excluded. So cotrimoxazole from 1 month will be started as a PCP prophylaxis. Immunization, follow the national immunization schedule. Rotavirus is not contraindicated unless severe immunosuppression. BCG at birth, if it is a very low risk or low risk, it should not be delayed. Okay, BCG will be given for very low risk and low risk baby. Now coming to the infant feeding. In UK, they follow the top feed. Okay, so formula feeding is recommended. No HIV exposure after birth. Support needed for women, psychological, financial, free formula should be provided. So lactation suppression with cabergoline, if not breastfeeding or if maternal viral load is more than 50. Okay, so preferred is a formula feeding. Now breastfeeding options. Breastfeeding may be allowed if viral load is less than 50. There is a good adherence and risk of transmission is low. Requires monthly maternal and infant viral load monitoring during and 2 months post weaning. And maternal cart, not the infant PRP, protects both mother and infant. Okay, so mother should be on cart. That will protect both mother and the infant, even if she is breastfeeding. Okay, but that is for viral load less than 50. Now this is the last slide, I guess. This slide is also asked. Okay, when will you test the baby? Okay, how is the screening of the baby is carried out post delivery for HIV? Okay, now we have two categories. One is a non-breastfed infants and other is a breastfed infants. Okay, so for non-breastfed infants, most of the babies will be non-breastfed because they follow top feed formula irrespective of viral load, but definitely it is a shared decision making. So if the patient viral load is less, but she prefers to breastfeed, then the baby will fall into this category. Okay, you got it. So now when the baby is to be tested, so the baby is to be tested for RNA PCR within 48 hours or before discharge. Okay, in a non-breastfed groups, and after 2 weeks after the prophylaxis. Okay, the baby will receive the prophylaxis either 2 weeks or 4 weeks. It may be monotherapy or it may be multiple drugs combined therapy. Okay, so you will do 2 weeks after the end of the prophylaxis or 8 weeks after the prophylaxis, and if it is high risk, then it is done at 2 weeks also. So for non-breastfed infants, you will do it 48 hours one test, then at 2 weeks after the PEP, then another at 8 weeks after the PEP. Okay, and if the baby is high risk, then at 2 weeks also it is done. Okay, and final testing of the HIV antibody is done at 18 to 24 months. So non-breastfed infants is very simple. One, you will do within 48 hours. Second, you will give PEP for 2 weeks or 4 weeks, and after the stopping the PEP, after 2 weeks you will do another, you will do at 8 weeks after the stopping the PEP, and then HIV antibody final at 18 to 24 weeks you will do. Okay, but if it is a breastfed infant, in that particular case, you have to do one at 48 hours. Second, always do at 2 weeks. Here 2 weeks is done only if the high risk it is there. Okay, then you will be doing monthly during the duration of the breastfeeding. Once she stops the breastfeeding, then you will do monthly for 2 months. That is 4 weeks and 8 weeks after stopping the breastfeeding, and then you will do HIV antibody test at 18 to 24 weeks. Okay, so for breastfed infants, 48 hours, then another at 2 weeks, then monthly till the duration of the breastfeeding. After stoppage of the breastfeeding, at 4 weeks and 8 weeks, you will carry out the screening by RNA PCR, and final will be at 18 to 24 weeks. Is it clear for the breastfed infants now?
Yes, sir.
Okay, and for non-breastfed infants, within 48 hours. Okay, for low risk and very low risk, 2 weeks after stoppage of the and 8 weeks after stoppage of the PEP. But if it is high risk, then you will carry out at 2 weeks also. That is why you should see the category of the baby and then you select the option. And finally is at 18 to 24 weeks. Okay. So that finishes the this particular BHIVA guideline also.